Thanks. Um, Hello. That and by the way, we don't have any cases today for HCV. No. Okay. Chantry's saying no. This is a classic echo didactic, so it's designed to be about 20 minutes long. So we'll have a lot of time for left over if anybody wants to spontaneously present a HCV case, or obviously the topic today is about tick-borne stuff, and we could talk about other tick-borne things. So I have a whole separate bunch of lectures on Lyme disease that I do for Echo. And so today is non-Lyme tick-borne illnesses, and they are becoming more common. We're seeing them more often, and it's certainly ones that we need to be familiar with because they can have significant consequences, just like Lyme. So, but as Chantry said, feel free to ask questions. We have nothing but time today, and so I would love to personalize this for any particular questions or comments that you have. I see Helen's on. Helen, there's some transaminitis with all these, so they can cause a hepatitis, but obviously not to the same degree as the professional hepatitis viruses A, B, C, D, and E. But they can present as transaminitis and stuff like that. And actually, I'll mention that for one of them in particular. So I always think this is fun because I love arthropods in general. I love arthropods. And there's just a reminder of the arthropod vectors that we could deal with. And just as a reminder, up here is our ticks, and then our mosquitoes, and then our flea. By the way, can you guys see my cursor? Am I on the right screen? Okay, good. Sorry, because I have two screens. I'm never sure which one. So here's our flea, and there is our this is our ugly louse. Scary. There's a mite, and obviously a fly and a bug. But we're kind of blessed in the U.S. in that we don't have a ton of a lot of the evil arthropod vectors that you have to worry about worldwide. But yeah, so by the way, the only fly I know that we have here that really causes trouble is the deer fly. A deer fly can carry tularemia here. And we do have reduvid bugs. You know, when I grew up, we called these assassin beetles, but technically, I guess they're reduvid bugs. We do have them in West Virginia, but they don't carry Chagas here. So there is no endemic Chagas, thankfully. And if we finish quickly, I can tell you how unpleasant these feel to be bitten by. I had never mind, I'll do it now. We have time. So I was by a campfire and did not look at the cup that was next to me. And I noticed something going down the gullet as I was drinking. Like as the water was going into my mouth, I saw something out of the peripheral vision, and I ate a reduvid bug. I swallowed it, and not before it bit the living thickens out of my mouth. And it's an awful experience. And actually, I will say I became a local expert on endemic Chagas because I wanted to make sure I wasn't going to be the world's first case of West Virginia acquired Chagas. So there's no trypanosomes, no human trypanosomes from our local reduvid bugs. But that hurts, by the way. Their mouth part is designed to drink the blood of other bugs or drink the body fluids of other bugs, but they're darn good at biting our mouth too. It's terrible. All right, so that's all the arthropods that can get you. If there's any questions on those. By the way, the louse that tends to be most troublesome is the body louse. This isn't like hair lice. Hair lice don't carry anything as far as I know. It's the body louse that does. And it carries a bunch of weird stuff, a bunch of rickettsial type illnesses called typhus. Typhus, not typhoid, not salmonella, typhus. So, but you get this one from not changing your clothes very often, body lice. Okay, so tick-borne diseases in the U.S. So going from just generic arthropod to ticks. Ticks are, kind of public enemy number one in terms of being a transmission vector. There's a ton of things that they can give us depending upon the particular tick that bites you and the geographic location there where you're bitten. But you fall into these many broad categories, and as you can see, there's a bunch of different categories, and each has its own subcategory. So basically, the rickettsial-like. So remember the rickettsial-like pathogens, small little obligate intracellular gram-negative pathogens closely related to our mitochondria, interestingly enough. But Rocky Mountain spotted fever tends to be one that we all memorize in textbooks and remember is a terribly named pathogen because it doesn't really happen in the Rocky Mountains. It happens in the East Coast. So I don't know why we haven't changed its name to East Coast spotted fever. That would just be too logical. It was named in a lab in the Rocky Mountains, so hence its nomenclature. But really remember that is something that we can find around here in the East Coast and Mid Atlantic. All right, Ehrlichia and Anaplasma, similar intracellular pathogens. What's different about the rickettsial species and Ehrlichia and Anaplasma tends to be the target tissue. So the rickettsia really like endothelial cells, so they're really an infectious vasculitis. So if you think of rickettsial species as infectious vasculitides, whereas Anaplasma and Ehrlichia are parasites of your or obligate intracellular bacteria of your white blood cells. So they live in your white blood cells. Okay. Then there's the spirochetes. So if you move away from the rickettsia type stuff, the spirochetes, and obviously the most common spirochete-borne or spirochete tick-borne disease is Lyme. That's the one we all know and we'll all see in our practice because it's so common. And then there's other ones that are much less common that we might see. But boy, oh boy, honestly, they're hard to keep these all apart, separated in your mind. But I'll go through some of them, not all of them. Then there's even some protozoa. We do have Babesia. So remember, this is another intracellular pathogen, but it's intra-erythrocytic pathogen. So this is in red blood cells. And think of it as the North American malaria. Okay. And then there's more traditional bacteria that can come from ticks. And the real one you worry about there is tularemia. Tularemia being a very plague-like gram-negative rod. And there's about 1 million ways you can get tularemia, by the way. You can get tularemia from a deer fly bite, like I mentioned. You can get it from a tick bite. You can get it from inhaling a carcass that you run over with your lawnmower, or you can get it from skinning an animal, like if you're a hunter. Classically, it's a rabbit, but it really can be a lot of different animals, including deer. I've seen people, the one case I've seen that was really bad was from a hunter that was doing a field dressing of a deer and didn't wear any gloves. So, all right. And then there's viruses. These viruses are scary, and I will promise you that we do not have a conclusive list of viral tick-borne pathogens because every year or two, like a new one gets named. Like this Heartland virus wasn't even a thing when I was training. It was, as you'd imagine, in the Heartland. And fortunately, they're sort of named from where they're from, except Powassan. Powassan is probably the one on this list that's likely in West Virginia. The other one's much less so. And then there's even weird things that a tick bite can do to you that are not infection related. They can cause a very Guillain-Barré looking paralysis. So if you ever have a patient who's presenting like they have a Guillain-Barré syndrome, make sure you do a good look over for ticks. And there are stories. There's many a case report of people having a tick found on them in the ICU after they're intubated for their Guillain-Barré. So it's pretty cool. Imagine being that ICU nurse who finds that. You're going to feel like a genius because you found the root cause, finding the tick causing tick paralysis. And then there's the weird red meat allergy, the alpha-gal thing. And I don't talk about that much because I don't know much about it. It's a allergy immunology concept, but it's I guess a tick's effort to make more vegetarians in the world. And but it can give people really potentially dangerous and potentially even fatal anaphylaxis. There's case reports of anaphylaxis for people who are exposed to a certain protein from animal source meats after tick bites. But anyway, impressive number of pathogens that could come from ticks. So, but I just want to educate about ticks so that we're all on the same page. They are parasites. They feed on blood, and they can bite all sorts of animals. So they're not just mammal pathogens. So, or I should say annoyances. They're not just mammal annoyances. They can bite birds and reptiles as well. And the picture there I promise that's a picture of a pre and a post-fed tick. That's also could be a picture of me when I leave Pizza Hut. I don't know why. That's how I always feel. Um, Eat entirely too much there. But they can engorge 2 to 6,000 or whatever, a lot. They can really get big. And so you can imagine it's a lot easier to see an engorged tick than a non-engorged tick. So ticks, I hear a lot of misnomers about how aggressively they hunt a human. And in general, they're opportunists. They sit on the end of some bit of vegetation or the ground with their arms up in a what looks like a prayer-like position. Their two arms are up, and it's called questing, and they're just waiting for some CO2 producing being to go by, or something furry or fuzzy that they can grab onto to go by. And they grab a hold and then they bury their mouth parts and go from there. So, but they're not predatory per se. They're opportunists. You got to bump into one. But boy, is it easy to bump into one. They don't fly, they don't jump, they don't drop from trees on your head. So that's a big misnomer. A lot of people tell me that, like, yep, they fell on my head. No, they didn't. They crawled up to your head. Okay. Tick quiescence is they can basically go into mini hibernation and survive for long time periods, and that's a bummer. I wish the cold temperatures always killed them, but remember they can go to sort of arrested development called tick quiescence. And this is an unfortunate reality is tick season. Classically, if you read textbooks about temperate areas like we live, where you're supposed to have 4 seasons, it's supposed to be spring through fall. But I promise you, we've seen Lyme disease in January. We've seen tick bites in January now, and it's just because you only need a couple days for the ground temperature to heat up above 45, and these darn little invertebrates can get enough wherewithal to move around and seek their next meal. I don't remember many Januaries or Februaries or Decembers that we've not had temperatures that warm, and so we just, such is the ever-changing experience of our climate, that we just seem to have warmer winters and as such more ticks and less tick death. So, okay. So how do ticks make us sick? It's really their saliva. So that tends to be most of the stuff, comes from the saliva. But in a gross manner, they can also, it can come from their feces. So if the thought of being bitten by a bug isn't gross enough, you're also being defecated on. So, and then try to get that picture down below out of your mind. Good luck with that. So there's some tick intercourse apparently. But how does a tick become infected with a pathogen? They can usually get it from a viremic or a bacteremic or a parasitemic animal that they're biting. So whether it be a deer, a mouse, a chicken, or something else that has an asymptomatic, or at least we think asymptomatic experience of that viremia, bacteremia, or parasitemia, and then the poor tick gets infected, and then can just pass it on like a living hypodermic needle. And then the tick can pass it from one stage to another. So if you remember, a tick's life cycle is measured in instars, and basically you eat, you get big and swollen, and then you shed and turn to the next phase. And then you do that 3 or 4 times, depending upon the tick. And then you mark your life as a success. And then you can be born as an infected tick. So sort of like congenital infection. You could have been you could be unlucky enough to be born a tick. And you could be born a tick with an infection. And we talk about nature's cruelness. Yeah. And then again, the picture there, I can't believe someone took that picture. That's wonderful. But the ticks can pass infection back and forth to each other as an STD. Amazing. All right. Exposure history. This is like the most boring slide, but probably the most important slide on here. Truly is. Exposure history is key. And the particular exposure history is incredibly simple, and I'll talk about it. So remember the clinical presentation for most of these disease states, it looks like everything else. Truly, it looks like COVID. It looks like the flu. It looks like some other non-specific febrile illness. You're just not going to see these unless you entertain the concept of, oh, maybe this, quote, flu-like illness or with this viral illness is tick-borne, or this bacterial illness is tick-borne, unless you think about it. So now the challenge is, what exposure history are you trying to elicit? And honestly, it's an ever lower bar in my book, because I see more and more. By the way, I would say 9 out of 10 people I see with a tick-borne illness don't have no known tick bite. There we go. That's better English. Yeah. So most people don't have a known tick bite, which is really disturbing. So what that means is the tick bit them, spread the pathogen, engorged, fell off, and completed its life, or went to his next phase of his life cycle, and we never noticed. And you might imagine how that's possible, but we're big creatures. It's hard to see our backs. It's hard to, and these things are small. They could be potentially small. I tell a story on this one. I pulled a tick off of my own knuckle, and I tend to be quite attentive to my, I pride myself in hygiene, wash my hands constantly, but I thought I was a scab. And then after like 4 days, I realized that scab was getting bigger and had legs. And I was like, oh my God. But it's really easy to miss these micro itty bitty ixodes. And so stopping thinking about tick-borne disease just if a person says they've not had a tick bite is a bad idea. Okay, so you really just need to say, man, everybody's at risk. Start there. And then what can make you at more risk? Basically being a West Virginian. So, and I mean that. So if you live rurally, if you like to ATV, if you like to, you garden, you mow your lawn, you basically live the Americana life of a rural human, you're at risk. Now, you can do things to really increase that risk. It's funny. Some of these are like being a bad golfer. Like literally your golf score correlates with like being a more tick prone if you walk in the, and I see some professions like the guys that work the oil fields and the people who, the poor guys who clean the underneath the power wires, the power lines. I'm blanking on but anyway, the guys who are in the brush all day long, like weed whacking and stuff like that. I cringe when I see them, because I'm like, man, but we see a lot of occupation related exposures from people who have to live and work in the outdoors like that. And then, a lot of us have pets, and it's funny how offended people get when I mention that their dog might have brought them a tick, and they're like, no, I treat my dog. Well, good for the dog, but not good for you. And so a lot of times the dog, so remember how we used to have West Virginia had a I can't remember what this called, the people that study bugs, but that's what he did for a living. I kept wanting to say ornithologist, but that's no. Anyways, an arthropod.
Entomologist.
Thank you, entomologist. Word finding difficulties. Yes, brain fog, left over from Lyme. Yeah, entomologist. Thank you. We had an entomologist, and you know how they find ticks? How they go out and catch them? They drag a furry blanket through basically a field, and it's like they're fishing, or they drag a furry blanket through there. And so what is a dog really more than a glorified furry blanket, or a cat? So and I'm always appalled / depressed the number of people who share their bed with their dogs. And so you can imagine a tick kind of riding in on that flannel dog, and then just being like, you know what, I can't bite you because you've got your flea and tick collar, but this one next to you doesn't have a flea and tick collar on. So I'm going to hop on this and give a bite. So, and that happens, but universally people are mad at me when I suggest that as an option. I'm like, stop sleeping with your dog. So, but anyway, so my bar for saying you're prone to ticks is like, starts with you live in West Virginia. Yeah, we're all at risk. And when COVID was a thing, this slide is from when COVID was a thing. The CDC police said, hey, we as clinicians are uber primed to think of COVID nowadays, but let's remember that we really can't clinically see, like we can't tell the difference between COVID and flu and tick-borne illnesses. So they said, please don't forget about tick-borne illnesses. Not everything's COVID. But the other thing where I really like this slide was it reminds us that when we're seeing somebody where we're doing a biofire, we're saying, let's look and see what that febrile illness is caused by. And when we strike out on our biofire for our respiratory illness, and we're like, well, I don't know what it is. Remember, tick-borne illnesses can really mimic COVID and flu, etc. things to look up, not to memorize, is a couple time factors. Incubation period is kind of nice. If you had somebody with a distinct risk time period, you can sometimes, that's something I always look up, So I've had people who came in the day after an outdoors exposure and be really paranoid that they have like instantaneous tick-borne illness. It's probably not. Most of these have a significant incubation time period, but you can always look those up. Time of the year, as I mentioned, classically was important, but becoming less so due to global warming and all that stuff. The one I've not found useful to be comforting, and in general, I view this as a clinical error, is using tick attachment time. And I'm going to give you my reason behind it. So there's good science that says we don't have to worry quite as much if a tick is not attached for a long time period. That's a true statement. Some of the pathogens are transmitted from the midgut of the tick or whatever part of their gut they have. And so that's Lyme. Lyme takes a while. You need to basically have the tick glue itself to you, start feeding, and then regurgitate its stomach contents into your skin. And that takes a while. So that's the 24, 36-hour attachment time and stuff like that. Now, some of them transmit, some of these pathogens transmit much more quickly, like powassan. Powassan can transmit in minutes, like literally minutes of bite time. And then Lyme and Anaplasma are quicker. I'm the wrong word. I'm sorry. Anaplasma bees here are quicker than Lyme. But I tell you what, why I don't give it any credibility or concern is if you saw a tick on you and took it off, what do you think the likelihood is that you have had a tick elsewhere on you? I bet darn high. And so I've read notes on people who have decided not to treat patients for a tick-borne illness because the tick was seen and removed quickly, or it was not attached. So just be very dubious with the thought process there, because it's, to me, a marker that they're in a tick-rich environment and certainly have a potential for exposure. I hope that makes sense. Doesn't mean you necessarily have to treat them with the 200 milligrams doxy prophylaxis stuff, but you can tell them be careful. All right. Yeah, and this is just the local ticks. And the more you look at these, and by the way, this is terrible pictures because it's not to scale whatsoever. The deer tick tends to be itty bitty, and the dog tick and the Lone Star tick tend to be quite a bit bigger. And there's variability depending upon the type of basically time of the year. They tend to be smaller. All of them tend to be smaller in the spring when they're the nymphs, as opposed to after they've gone through a few instars and get bigger with time. But it's something that you can Google. Fortunately, the Lone Star tick's kind of easy to identify. But honestly, sometimes a small dog tick and a big deer tick can be hard to tell apart just by memory. So I usually will put them up next to a picture to help me identify them. One of the services that I think you could talk to patients about is sending a tick off to have the pathogens in it identified. And I need to clarify this. The professional societies that I represent, or should say that represent me, that's better. I send them money, so never mind. They represent me. They tell you not to use these. So but I'm going to give you a different opinion. So, and the rationale, and what these are is basically you send a tick in a baggie to one of these labs. There's a bunch of labs around the country. You send them a tick and your money, and then they'll tell you via PCR testing what's in that tick. And the other cool things they tell you is what type of tick it was. They tell you what the engorgement time was, like how many hours it was attached. And then if you really want to pay extra money, they can tell you everything else that tick bit, which is really cool, because it can be like, yeah, that tick ate from a turkey and then a raccoon and then you. And I firstly find that fascinating, because I found out I was blood brothers with a raccoon now, and I was stoked on that. But anyway, I like these services for one reason and one reason only. They're negative predictive value. So if you send a tick in, say, and I'll give you this distinct example. A young little girl pull a tick off of a neonate. Antibiotics are a big deal when you're little. You don't want to necessarily be exposing kiddos to a young kid. Ideally, they would get some form of antibiotics afterwards to help prevent whatever's going to happen. But is there a way you could avoid that? And yeah, so if you send the tick off and the tick doesn't have anything in it, no pathogens, you can rest at ease. So I use this for the negative predictive value, number one. And number two, to teach people what pathogens are in their environment. So I think that that's fun. Um, your definition of fun may be different, and your definition of fun may be limited by how much extra money you have in your pocket, because these are not cheap. They cost anywhere from, I think $25 to $40 is the cheapest you can get one for nowadays. But if you really want to do an expanded testing, you can spend $120 per tick you send in. But yeah, worth it. But just remember, the professional societies disagree with me, and because it's not necessarily true whatever's in the tick is in you. Okay, so just remember, because it may not have transmitted that. But that's the debate and controversy with these. I personally like them for the reasons I mentioned. So I wanted to talk about these particular ones today. Not all of them. We'll go quick. But what diseases can be spread from the Ixodes? So right now, the scourge of West Virginia is the Ixodes, the small black deer tick, the itty bitty black deer tick. And we have so many of them now. They are only been here for about a decade and a half. So it was really about 2010 and on that we started getting these. But the disease states we need to really worry about is Lyme, several other spirochetes in the Borrelia subspecies, and then Anaplasma, Babesia, and Powassan. And so that's a lot. I mean, that's a lot of different things that one silly tick can give us, but we'll go through a couple of these cases. This was a great case. By the way, any questions so far? All right. So this was a 74-year-old female, and I really want to emphasize her age. We're already entering with our bias. We're like, well, you don't get tick-borne diseases crafting. You don't no, but a 74-year-old with dialysis, and just the usual suspects. So some diabetes, AFib, RA. Okay. So she had a left chest port and a tunneled cuff catheter. I don't remember why she had her chest port in. Always a bad idea. No infection doc is ever a fan of a port, but especially that you don't need. And did have a tunneled cuff catheter she required for dialysis, but basically presented with a febrile illness, high-grade febrile illness, and kind of shocky. So hypotensive, looking ill, and was weak and ill enough to be falling on occasion. So she had bumped her head and had a headache, but it was more attributed to the fall than anything else. And really, that was about it. She had negative review systems. Hard to tell. In other words, it wasn't claiming an organ system. This wasn't a pneumonia. This wasn't a UTI. This wasn't a sinus infection. This wasn't a gastroenteritis, stuff like that. Scary looking vitals because she's very febrile and hypotensive. She couldn't move well because she was generalized weak, but didn't seem to have a stroke. Just generalized weakness. And again, had these ports. So these central vascular access. Imaging, and really didn't show much. So it said, yeah, really not much. I don't know what to do with bladder wall thickening in a dialysis patient. That's probably normal. I don't think they pee much. But her, look at this CBC. So 1.9. So what does that tell us? It doesn't say anything, but it scares us. So remember, leukopenia. Helen's patients have leukopenia because they're cirrhotics. Remember, a stable outpatient cirrhotic can have leukopenia. But in the setting of somebody with a fever and acute illness, that sounds like sepsis. That sounds like a septic patient, especially with this left shift, this bandemia, and then thrombocytopenia as well, and liver enzymes are high. They're not in the realm at all of acute viral hepatitis. The professional acute viral hepatitis is like Hep C, B, E, or D, but they're abnormal. And obviously her creatinine's not reliable, and we can see some of her markers of inflammation are elevated. So, and the first thing you'd be thinking in this lady was exactly what the ER thought, and they're thinking Lyme infection, and that's exactly what I would think too. It's what kills dialysis patients? Lyme infections. That's a real good thought process. But nothing grew. That would have been caused of some contaminant, Aerococcus grew from her urine. I don't know what to do with urine cultures in dialysis patients either. I don't ever know if they matter, but punchline is we weren't comfortable saying that was the cause. It wasn't seeming to be UTI. Our blood culture stayed negative. But and I copied and pasted this social history because this is the social history that Epic records. There's not a lot on there. Nothing that I can garner any risk from. So we did a better social history. So we said, hey, lady, what do you do? And she lives in a rural area in Western Maryland. She's outside all the time. She has 2 bird feeders that she walks out through shrubbery and long grass to fill every day. She has tons of raccoons and deer in her yard, cats. In other words, we suddenly take this lady from somebody who didn't have the bad habits of daily living to somebody with wow, does she seem tick prone? And even though it seemed like her case is screaming Lyme infection, we said, you know what? If you entertain tick-borne infection, you treat for tick-borne infection. Started her on doxycycline on hospital day 3, and she went home like soon thereafter. And then our PCR came back after she went home saying she had anaplasma. And so this was a really good case. But again, her differential's got to be massive. And remember, any community-acquired sepsis syndrome can present like this. And the common community-acquired sepsis syndromes for older people, we would include strep pneumo, other bacterial sepsis, and then obviously weird stuff. And we got to remember the tick-borne illnesses and those weird things. So we relied on a PCR to make the diagnosis for this patient. But if you have a pathologist that's really good at looking at peripheral smears, they can sometimes see these neutrophilic inclusions. This is a morula, and this is a white blood cell. This is a PMN. And so the intranuclear inclusion called a morula. So you can make a really quick diagnosis under a microscope if you have a good pathologist, a hematopathologist that's good at checking these out. And if it's in a granulocyte, it's anaplasma. And if it's in a lymphocyte, it's Ehrlichia. So really those are the 2 bugs I want to talk about that can come from the Ixodes tick here. So Ehrlichia is the one that Ehrlichia and anaplasma, and there's a couple different vectors for them, but they can be a Lone Star tick, can give you the Ehrlichia more so. The anaplasma, which is the one that carries the Lyme, tends to come from the tiny little black-legged deer tick. So I would say I have not seen right around here in northern West Virginia Ehrlichia. I do know that some of my colleagues in the southern part of the state have seen Ehrlichia itself. You don't clinically differentiate these. They just it's basically you think you have one of these, and then the lab tells you which one, or the pathologist tells you which one. But clinically, they all look the same. And again, you can see we live in an area of overlap between Ehrlichia and anaplasma. And again, I don't have to be a splitter on these. And again, they are a pathogen of the white blood cells. They're not necessarily an infectious vasculitis, unlike the rickettsia, but boy, they present similarly. I really like this slide. So you remember I said I was biased against the tick-borne disease because she was in her 70s. Boy, was I wrong. But look at the highest risk groups for anaplasma. So it is when you're older. So it's this is all the people with their little pet Shih Tzu or whatever, their tiny little pocket dog that probably goes outside. But this lady was robust. She was awesome. She was out charging, feeding birds, and hanging out with her deer and stuff like that. And she got a tick bite, and there we are. So how are these anaplasma and Ehrlichia similar to RMSF? They present as a flu-like illness. So flus, achy joints, flu-like illness, achy joints, and a lot of headaches. Remember, this lady had a headache, but it was attributed to her falling and hitting her head. And by the way, the headache can be profound. The headache can be scary enough that they get LPs. And they can have mild CSF pleocytosis with these disease states. So you can have that stuff. Seldom a rash. Now, remember, this lady was pretty thrombocytopenic, so you can get petechiae, but it doesn't tend to be it's not as rashy as the rickettsias. Remember, the rickettsias, as I mentioned before, are genuine infectious vasculitises. So you see more vasculitis-looking rashes with the rickettsias, where these anaplasma Ehrlichia is more petechiae from thrombocytopenia. And again, it can last a while. These are disease states that can last into the 2 to 3 week zones or even longer untreated. And they can really hurt you. I will say, I don't have this up here. The other thing they can do, they can really, especially with that white blood cell counts, they can mimic a leukemia in a scary way. So there's not uncommon for these patients to get seen by a hematologist or even transferred to see a hematologist because they have white counts less than 1 or platelet count. I've seen platelet counts in the single digits from anaplasma. So it can really cause profound pancytopenias. And like I mentioned before, liver enzymes can be high. This pattern, this leukopenia with left shift, thrombocytopenia, and liver enzyme abnormalities, buys you doxycycline without another answer. So I think that's the biggest, most important message. If you see this pattern and you're entertaining the person to be at risk of a tick-borne illness at all, then usually you start doxy and prove yay or nay later. But if it's a community-acquired sepsis syndrome or community-acquired febrile patient with that disease, with that lab pattern, we start doxy and ask question or answer the questions later. And that's kind of what this statement says. Diagnosis acutely is clinical. Nowadays we really use PCR to help us because there's great PCRs you can send. But remember, the pathologist can also help you before that PCR comes back. I don't order serology. I really don't. I know it says up here, but I never find serology helpful. It's a terrible mechanism of testing because the acute serology is never what you're looking for. It's the convalescent. So it's an unrewarding way to look. I would certainly never gonna use serology to confirm a need for treatment because the patient would be better or dead by the time your serology comes back. So use PCR or hematologic, ask your pathologist to look at the slide, and you treat with doxy. And it's a cool duration. You basically treat people until they feel better and then a little bit longer. So, and that's usually somewhere in the realm of 5 to 10 days. But yeah, okay. Questions on Anaplasma ehrlichia. We've seen a ton this summer. The most I've ever seen is this summer. So, okay. So 21-year-old student, so this one's young, presenting with 3 days of fevers, chills, and arthralgias. That's basically the exact same HPI as the last patient. And that's what I want to emphasize. There's nothing you can tell about these disease states from the actual, subjective. They're presenting with the sequelae of cytokine activation, that flu-like illness that accompanies 80% of the diseases I see. So fevers, chills, arthralgias, not feeling good. Recently came back from New Jersey, the Pine Barrens. Oops. The lovely part of New Jersey, by the way, if anyone's ever been there. There actually are lovely parts of New Jersey, despite what you'd imagine on Jersey Shore. There's lovely rural parts. And patient comes in quite ill appearing, quite febrile, no rashes, and really a non-focal exam. Does look like they have a scar from a prior, probably splenectomy. And the labs, again, we have this leukopenia. And then what's really unique about this one is the low hemoglobin. And they mention a haptoglobin decrease. So they must have been working up this hemoglobin and realized there's some degree of hemolysis. And again, the pathologist can give you the answer here. So you can see something in a red cell. And, we don't have malaria, knock on wood, here yet. But we certainly have Babesia. So this is going to be an intraerythrocytic North American protozoan as Babesia. And again, it comes from the darn black-legged deer tick that can give you Lyme and Anaplasma and the whole thing. So we do have it locally. We have it here. I could have told you that about 5 years ago I'd not seen a case, and we are seeing increasing cases in West Virginia. In my own personal experience, the cases seem to be more common in the Panhandle to the north and up near the Wheeling area and out east. But that's not to say I would ever use geography to exclude the likelihood anywhere in our mid-Atlantic area. And yeah, this is an RBC parasite. So it tends to act just like malaria insofar as it gets in their RBC, multiplies, ruptures, and then continues its life cycle. Does not tend to have the periodicity that malaria has. So, when you learned in med school all about the periodicity of various malaria subspecies, there's something to memorize. Thankfully, we don't really tend to see that with Babesia. It just causes high fevers. So, and it without any regular, predictable episodic component. And again, this can make you sick. We actually had a fatal case of Babesia this past year, or I guess it was 2025. And so it can just like malaria, it can kill you. So it's one of these things you don't want to miss. And it can be really severe if you're immunocompromised, asplenic, or elderly. So you remember this patient was asplenic, so it would be a really, really concerning situation. Definitely one you wouldn't want to miss. And it can last a long time. So a lot of the tick-borne illnesses, besides Lyme, are acute. So Anaplasma, Ehrlichia, Powassan, all these, they tend to come and hit you, and then you get over them. But this is one that can smolder for months, and take a long time to get diagnosed. So if you had somebody who seems to have an FUO, fever of unknown origin, and a risk exposure for ticks, and and some hemolysis on their labs, think about it. So again, lab findings. It can have the same tick-borne findings that we'd expect to find for the Anaplasma and the Rickettsia. So you can have a low to normal white blood cell count. You can have mild transaminitis, just like the other tick-borne illnesses. You can have a thrombocytopenia. But what's unique about this one is the hemolytic anemia component. And so again, you have that elevated LDH, your low haptoglobin, your anemia, and stuff like that. So, and again, the quickest, best way to diagnose it is to ask an experienced pathologist to look at a thick and thin smear and see if they see something that has an intra-erythrocytic pathogen. I have never ordered serology. Same reason, really unrewarding. Can show just past exposure. I don't really know the clinical utility there, but we have a good PCR for that one as well too. A lot of labs nowadays have a combined PCR for tick-borne illnesses. That's what we have at Ruby. We literally order is tick-borne panel, and it has Anaplasma, Ehrlichia, and Rickettsia, and Babesia PCRs. Now, the only bummer is it takes a week or so to come back. And so you don't want to wait on these disease states. So again, if you're entertaining one of the Ehrlichia, Rickettsias, or Lyme disease, treat with your doxy and then prove it later. You know, doxy, I have a joke about doxy where stewardship for all antibiotics except doxy. You know, in general, we try to be really purists with antibiotic usage, except doxy, because man, it's it's relatively safe. B, I don't consider it for other routine pathogens usually be a life-saving drug, so I don't really care about developing resistance as much. And the disease states that we treat with doxy are hard to prove. They're genuinely hard to prove. So they're hard to get these tests back, especially in a timely fashion. And so a lot of times we give doxy empirically, maybe over so, but I'd rather be safe than sorry. So remember with Babesia, it's not doxy. Your magic is this other combination, the AA combination. So azithromycin, which probably everybody knows, that's our Z-Pak drug. And then atovaquone may not be a drug that y'all are familiar with. It's an anti-malarial that we tend to use for PCP prophylaxis. It's probably the only time you might have seen it used for other things, but it's super well tolerated. Azithro and atovaquone, of the two, the more challenging to use is the azithro. So really, atovaquone's well tolerated, easy to use. And so I don't really hesitate to give that cocktail empirically while I'm waiting for tests if I have a high suspicion. The degree of parasitemia can be profound. Like that one case we saw this past year where the guy didn't make it, had almost 50% of his red cells were full of parasites. And, you know, that's terrifying. And so there are times when pathologists know tricks where they can suck out your red cells and give you new ones, these exchange transfusion things. But remember, that's on the table too if you got somebody severely ill. So just a little take-home message on these co-infection things as opposed to just Lyme. When should you really think of them? You know, Lyme disease can cause fevers, obviously, but if you are successfully treating for Lyme or your usual tick-borne illness, and the person's not getting better on doxy, remember that Babesia. So, and remember those co-infections. So, and then if you had any evidence that it was just a hemolytic process, not terribly common for the routine Rickettsia, Lyme, or Anaplasma. So, yeah, just that's the thing there. And again, open the floor to any questions that you guys may have or any stories. I prefer stories; those are more fun. So if anybody has any stories about any tick-borne illnesses they've seen this summer, it's every summer I say it's the worst summer I've seen, but so far I don't even think that's a hyperbole. It really seems to get worse every year. Thank you to our warming world, our open sky dumpster that the CO2 is helping us with. So anyway, questions.